Well, thank you, Jeff, for that very nice introduction. And we had Jeff out to Cedars-Sinai to Los Angeles last year, and he was terrific out there. So it's fun to come back and see you. Had a lovely dinner last night with, I'll just mention a couple of them, Jeff and a couple of the, let's see, well, I guess 4 of the fellows, wasn't it? It was Andrew and Conrad and Adidapo and Chaitra, all of them at dinner last night at the Conrad Hotel. And so we had a lovely time. What I'm going to talk to you about today is in this book called The Heart Healers. I wrote it about 2 years ago. It was transiently a bestseller on Amazon.com in its category. I think, you know, Amazon.com has so many categories, it doesn't mean very much. This might have been cardiology history or something that was the only book, I'm not sure. But in any case, it got terrific reviews from both doctors and from particularly from the lay public. I wrote it really for the lay public. And fundamentally what it's about is the history of cardiology in my lifetime, in my medical lifetime really, and it's an astonishing story that most of our young trainees know nothing about. And so this is to share with you the incredible things that happened prior to your entering cardiology. And I want to also tell it in terms of what it teaches us about creativity today, for those, particularly for those of you who are interested in pursuing anything that involves research. So what happens, our story begins a half century ago, a little over a half a century ago, with the discovery of antibiotics. And heart disease first emerged as our #1 killer. Prior to that, during World War II, infectious disease was our #1 killer, and then it switched when penicillin was discovered in the middle of the war. So as soldiers returned from World War II, we had at that time no heart surgery, no defibrillators, no pacemakers, very few drugs. We had morphine, nitroglycerin, digitalis, and no coronary care units at that time. We were basically like this iconic Norman Rockwell painting. We had very little to do for our patients in cardiology. Imagine the kind of change that was to occur. And so we had no effective treatment for congenital heart disease, valvular heart disease, or coronary heart disease. And what we're going to talk about now is how we got to where we are today. So our story begins with the first turning point appeared in the midst of World War II when this man, Dwight Harkin, he was an inexperienced 34-year-old Harvard surgeon who was assigned to be the chief of thoracic surgeon at the 160th General Hospital in London. It was a battlefield hospital. I got to know Dwight years later when he was at the Brigham and Women's, it was then called Peter Bett Brigham, now Brigham and Women's Hospital in Boston. And he was a fascinating guy. He was a fiery redhead. In the operating room, he was fierce. He would throw things and carry on, and then he would come out of the operating room and be the nicest, most charming person you have ever met. And so he was, as Roosevelt, who was president during the war, was described as, he wanted to be the baby at every christening and the bride at every wedding and the corpse at every funeral. He wanted to be the center of attention, and this was Dwight Harkin. Behind his back, whenever he got mad, because he was a redhead, he would get very flushed in the face, so behind his back we called him the Great Red Man. And Dwight then, when he was in London, faced this. Something he had never seen before in Boston, obviously. There were bombs coming down from above, there was rubble on the ground, all over. There was shrapnel protruding from the hearts of young men brought in with their chests blown open during war. And he was quite aware of, booming down through the decades, the voice of Theodor Billroth of the Billroth procedure, a Viennese surgeon, who said, "A surgeon who tries to suture a heart wound deserves to lose the esteem of his colleagues." And from England came the voice of Stephen Paget, who said, "Surgery of the heart has reached the limits set by nature. No new method and no new discovery can overcome the difficulties that attend a wound of the heart." But it is said that a pile of rocks ceases to be a pile of rocks when a single man gazes on it, bearing within him the image of a cathedral. And in Dwight Harkin's mind, there was a cathedral that he had. His vision was that he would be the first to repair the heart from an injury such as this. And so he tried anyway. And imagine yourself now, at this point in time, you have a soldier with shrapnel protruding from his heart, waving back and forth like an insolent metronome, and you put a clamp on that piece of shrapnel and yank. And here's what he wrote to his wife the next day in that amazing moment afterwards. Then suddenly, he put a purse string suture on the heart, and then his idea was he would tighten the purse string suture and add more sutures as he proceeded. Then suddenly, with a pop, as if a champagne cork had been drawn, the fragment jumped out of the ventricle, forced by the pressure within the chamber. Blood poured out in a torrent. I put my finger over the awful leak. The torrent slowed, stopped, and with my finger in situ, I took large needles, swedged with silk, and began passing them through the heart muscle wall, under my finger and out the other side. With 4 of these in, I slowly removed my finger as one after another was tied. Blood pressure did drop, but the only moment of panic was when we discovered that one suture had gone through the glove of the finger that had stemmed the flood, and I was sutured to the wall of the heart. We cut the glove and I got loose. And years later, when he would tell us this story, we would say behind his back, well, he could have cut off his finger and got the same result. But this was then the birth of cardiac surgery, the amazing story of how we got started. So cardiac surgery was born when a maverick, somebody who challenged conventional wisdom, did so. So what is a maverick? Well, as Steve Jobs says, here's to the Misfits and the Mavericks, the square pegs and the round holes. You should know that they can challenge conventional wisdom. They don't care for the rules. You can vilify them or you can praise them, but you can't ignore them because they change things. Some see them as crazy. I see them as genius because the people who think they can change the world are the people who do. And that is what the Mavericks in this story of your profession essentially did. So Harkin returned to try his method in mitral stenosis. His idea was that he would insert his finger through that purse string suture with a blade on the end of his finger and use it to slice open the fused leaflets of the mitral valve. And when he did this in his desire to become the father of cardiac surgery, he ran head-on into a battle with Philadelphia's Charlie Bailey. It was a classic battle. It was Chamberlain versus Russell. It was the Patriots versus the Eagles. It was a battle of the silk stocking man of Harvard versus the hardscrabble kid from New Jersey who was raised as a single parent because his father had died, coughing blood into a basin because his father himself had mitral stenosis. So this was a messianic effort by Charlie Bailey. He was cantankerous and he was charming. And between them, they had, as they tried this procedure, 10 consecutive deaths with not a single survivor. Charlie Bailey's first patient died on the table with the heart open and just pumping blood into the operative field as he tore the atrium apart. So I want to ask you, were they ethical to continue at that point? And you need not answer, but you need to think about it, because what happened then was that Bailey had privileges at 5 hospitals in Philadelphia, and barred from 3 of them now by the hospital administrations themselves. He was called Butcher Bailey, behind his back by the nurses at Hahnemann, and he had the physicians of Philadelphia clamoring at the Pennsylvania Department of Medical Affairs to withdraw his license to practice medicine. And so, taking his last shot, he had 2 hospitals left that he had privileges. And he scheduled 2 patients on the same day, one at Philadelphia General, one at Episcopal Hospital, and he went ahead. The one at Philadelphia General died during anesthesia induction, so he never really got a chance before the patient died to even try. So he asked the attending physician to declare him dead so that he wouldn't be blamed for the patient's death, and then gave it a try to open up the mitral valve, and it did not work, and the patient died. So he stripped off his gloves, raced across town to Episcopal Hospital on the other side of town, and hoping that the car would be faster than the telephone, I suppose. And he proceeded to operate there, and he had a spectacular success. The 23-year-old lady on whom he operated was up walking around the wards on the 3rd day. At the end of the week, at about day 8, he took her to Chicago, presented her at the American Society of Thoracic Surgeons as a success, and what then followed was that Harkin succeeded finally 3 days later. So 0 for 10 and then 2 for 2. And what happened was Charlie Bailey appeared on the cover of Time magazine, and Dwight Harkin was elected president of the American College of Cardiology. Fascinating kind of irony, is it not? Because it essentially shows society's ethical paradox. Before the success, the operation was widely viewed as unethical, and after the success, it was considered a laudable advance in the practice of medicine. And this is the interesting dilemma that people who try to make advances face. So now surgeons wanted to go, this was of course outside the heart operating, now they wanted to go inside the heart. And to do that, they had 3 challenges. First, they had to arrest and restart the heart, they had to circulate blood during cardiac arrest, and they had to oxygenate the blood. And at that time, no one had any idea about how you add oxygen to blood. So I want you to think right now, before I tell you how they resolved the problem. Can you think of a way to pump oxygenated blood around the circulation of a child's heart without being able, without knowing how to oxygenate the blood itself? And while you think about that, I will introduce you to this man, Walt Lillihei, fascinating man. He was in his last year of surgical residency at the University of Minnesota. He had lymphosarcoma of the parotid gland. He had extensive surgery. The dissection went down into his mediastinum, and his surgeon, Owen Wagenstein, predicted a 5% likelihood of 5-year survival. Walt in the hospital was a terrific doctor, charming guy, witty, very sensitive to patients, good doctor in every way. But outside, he was a hellraiser. He drank and lived a life of sin, and he was a hellraiser. Here's what Walt Lillihei came up with. His brilliant intuition was, he said this: if a mother's baby supports a fetus, why couldn't it support, if a mother could do that, why couldn't the mother's circulation also support the child outside the body? And so he came up with the idea of cross circulation. If I connect the mother's or parents' blood vessels correctly to the child's, the parent's heart can circulate the blood in the child while I operate, and that will provide oxygenated blood throughout the system. That brought him in conflict with the very principal chief of medicine at the University of Minnesota. And Cecil Watson said, for the first time in history, a surgeon may have a 200% mortality. I gather 100% mortality was probably acceptable in those days, but 200% was beyond what Cecil Watson could stand. So Lillihei went ahead anyway, and he was successful. And here is the Gray Lady, the New York Times, very staid in 1954, trumpeting impossible surgery now done. And it really was impossible surgery. He sutured a atrial septal defect, closed it in a child of about 4 or 5. Here she is, cute as a button. Walt was very savvy to publicity, and he had a press conference, which at that time was considered unethical, at the University of Minnesota, threw open the auditorium doors and brought in little Pamela, and by the end of the time, as he showed his charts and described what he had done, there wasn't a dry eye in the place, because he also brought in the parents who described how sick she had been. She was near death prior to the procedure. So Pamela was chosen as Minnesota's and American Heart Association's Queen of Hearts. She had a 6-page picture spread in Cosmopolitan magazine, and Lily High gained admirers around the country, and of course further infuriated Watson, who's we can imagine his eyes boring into the back of Walt Lily High's head as he walked around the University of Minnesota Hospital. And then what happened? And so what this shows us in terms of how Mavericks behave, that was a thought completely outside the box. I wonder if any of you thought of it. Probably nobody else did it at the University of Minnesota except for Walt. But then what happened, although he had proved the feasibility of open heart surgery, then came the most awful moment in all my years of going to medical meetings. He went to the national meeting, and as he was presenting his early results with cross circulation, somebody from the back of the room yelled, "Admit you have a vegetable in the hospital." And it was true. Geraldine Thompson was her name, was a 34-year-old woman with 4 children, and she sustained an air embolus because the individuals connecting up the tubings of the child and the parent had allowed air to enter the tubing, and she was sufficiently damaged that she could no longer take care of her children. She survived, but that was essentially the end of cross circulation. Lily High continued, but nobody else in cardiology would do it, and cardiologists were very reluctant to try to refer for the use of cross circulation. And so, although cross circulation died that day, Lily High's success led to John Gibbons and the heart-lung machine. Not well known nowadays, John Gibbons. I think Andrew knows him because he went to Jefferson, but most people do not recognize that name. And yet, he was essentially the inventor of the heart-lung machine. But his story is also crazy. The first great breakthrough in cardiovascular technology is this man, John Gibbon. He was a Philadelphia patrician. He was 5th-generation physician. He had a house out on the main line and another place that he stayed in town near Jefferson. He put on large, very elegant parties at his main line home. He was artistic and sensitive. He didn't really want to go into medicine, but his father and grandfather insisted that he did. And so he went to Harvard, and he then got involved in, he had a patient who died, a young woman who died, and he got very interested in the possibility that he could have saved her if he'd had a heart-lung machine. And so he did research for 22 years trying to develop a device that would deliver oxygenated blood to a patient during surgery. And he was only able to get to the level of doing it in cats for about 10 or 15 minutes that he keep the cats alive. And it essentially came down to his inability to effectively oxygenate blood. And so he met at one of his society functions the founder of IBM, Watson, and Watson sent 5 engineers down to Philadelphia. They participated with Gibbon in the work in his animal laboratory. They solved the problem of oxygenation and built this machine. And here is John Gibbon. His first successful surgery took him 26 minutes on the pump to close an ASD. He was not a very skilled surgeon, as opposed to Lillehei, who was highly skilled. Lillehei would close an ASD in about 6 minutes. But in any case, Gibbon did succeed on a 18-year-old college student at Wilkes College in Wilkes-Barre, PA. And then he used the machine twice more, and both children died. And Gibbon was a very sensitive guy, and at age 49, the guy who invented the heart-lung machine quit and never used the machine again. He said, I'm calling a moratorium on this because I can't deal with with child mortality. But he had at that point opened the door a crack, and the incandescent light of possibility shone for other surgeons who were now cardiac surgeons. There were no cardiac surgeons, of course, when Harkin did his work. And so this young guy, he's 31 years old, came out from New York to set up the first cardiac surgery program at the University of Oregon. And this guy, Lowell Edwards, came in to meet with him about a year after he had been there and wanted to create an artificial heart. And Starr said, well, let's not do a heart, let's just do a valve. And so they decided that they couldn't possibly try to recreate a valve per se, and they decided to go with a mechanical valve. They stole the idea essentially from a man who had put a valve like this, a ball and cage valve, in the aorta for treatment of different disease, and put this valve in the aortic valve position. His first patient, they had to set up essentially a post-op coronary or cardiac care unit, and she did fine at surgery. And then he came in to see her on the first post-operative day, and she said, I'm feeling really stiff, can you help me roll over? And as he helped her roll over, she died suddenly. And it turned out that what had happened was there was a large volume of air that had got into the left ventricle, again because of misapplication of tubing in terms of the anesthesiologist allowing air to get in. And she had an air embolus and died. From that time on, surgeons, when they unclamp the aorta at surgery, do it in the Trendelenburg position so that if any air is there, it doesn't go to the brain. Starr, like Lillehei, had a 50% mortality in his first year. Second year, it went to 25%, and then it progressively fell over the years. And that was the birth of prosthetic valve surgery, coming off of Gibbon's invention that he then abandoned. And also, at roughly the same time, this guy, funniest guy that I've ever met in cardiology or cardiac surgery, a wonderful guy, Norm Shumway, at Stanford. He had trained with Lillehei, and he spent 8 years perfecting cardiac transplantation, which was a difficult procedure at that time. Initially, he did auto transplant. He would take the heart out and then put it back in again. And then he developed transplant from dog to dog, and he cut a cuff of the atrium so that he connected two atria together, and you would see ECGs in people with two P waves in these patients. He spent 8 years projecting the ability to do cardiac transplantation, and then Stanford blocked his try in humans because they said it was too great a legal risk, that he would be harvesting hearts for cardiac transplantation. And so this man, Christian Barnard, at Grootegeer in South Africa, in Cape Town, did the first procedure. Bernard was a very interesting guy. He was very egocentric. He gave no credit. When he came to the United States and described his results later, he gave no credit to anybody but himself, having done this, and was rather widely disliked in the United States. Bernard only did 9 cardiac transplantations in his entire life. He But the announcement on a Sunday morning, I recall the day it happened, that he had done this galvanized the entire field of cardiac surgery. And in the next year, there were 99 cardiac transplantations done. Essentially, everybody died because they had no idea about how to manage the immunotherapy post-procedure. And so it was something of really a scandal in our history that cardiac surgeons just went crazy over doing cardiac transplantation and failed miserably. Then in the 1980s, he finally solved the problem with the discovery by Sandoz of cyclosporin, and that was the beginning of successful cardiac transplantation. So this is the hare and this is the rabbit in the procedure of cardiac transplantation. Recognize her? Sophia Loren, yes, the famous movie star. Whenever Bernard was married 3 times, and every one of them was a beautiful heiress. So he was very, that was one of his major interests when he traveled the world. So cardiac surgery, my friends, was born on a river of blood, much of it the blood of young kids, because of that 50% mortality that Lily High had, and subsequently that Al Starr had. So it's interesting for you, and I would like you to wonder about, as we talked at dinner last night, would the breakthroughs that I'm describing to you occur today? And what would have happened if we had, if we had stopped them, as I would have as chair of the IRB? I would not have let this go forward. Well, the complications of heart surgery fathered the development of electrophysiology, and here's how. This man, Claude Beck, he was a thoracic surgeon in Cleveland, had a 14-year-old boy with pectus excavatum, and as he was closing the chest, that young man developed ventricular fibrillation. At the time, nearby was Carl Wiggers, a world-famous physiologist who had just begun doing studies on a defibrillator that he could put on the animal's chest, and he could induce ventricular fibrillation and then defibrillate him. So Beck, while gloved in the operating room, demanded that Wiggers' device be brought into his operating room, and it was brought in. I'm sure he wiped off the paddles to make sure there'd be no infection, and he applied the paddles, and after the second shock, he was able to resuscitate that child. Now imagine that moment. For the first time in the history of mankind, a person who is dead has been brought back to life. And that's what happened in that operating room at that time, the biblical vision of Lazarus being brought back to life. And so Beck's experience then, he reported it and in the journals, and it led to cardiac defibrillators. He got so enthusiastic about this. This is one of the first defibrillators with the paddles to be applied directly to the heart. Later, only about a month after this episode, he then slashed open the chest of a doctor who had come in for surgery in the outpatient area, and he cut right through the shirt of the man and opened up the chest and began squeezing, and then demanded that the defibrillator be brought and defibrillated him. That guy also survived. He lived to be 94, he vastly outlived Claude Beck himself, and went back to practice here in Florida. His name was Sansone, S-A-N-S-O-N-E. And so he did that, and now Beck, he was so taken with this that he demanded that all his residents carry a scalpel in their white coat, and whenever somebody hit the floor, they were to go ahead and do this. And so a period now of about 2 or 3 years maybe, I remember this, of slashing open chests for manual massage occurred. And Richard Ross, who was chief of cardiology at Hopkins at that time, liked to relate his own experience, apocryphal perhaps, but he said that he had fainted, and when he woke up, there was the cardiac surgeon poised above him with a scalpel. And I said, well, you know, Richard, I was involved with a turf war at the time with our cardiac surgeon, Jack Matloff, over various issues at Cedars. And I said, you know, the same thing happened to me, except I hadn't fainted. So that was the period of a remarkable period in American cardiology, briefly. So the medical device industry then emerged from another surgical disaster, which was heart block. And what happened was that 20% of Lilly High's surgical mortalities in kids were due to heart block induced by damage to the conduction system when he operated on VSD and ASD. And so he looked around and he said, well, I got to play the cards I was dealt. There was a repairman who came in to the hospital, picked up hospital equipment, and took it back to his garage in Minnesota. This is the garage. And Lilly High asked him if he could help. Earl Bakken, this young guy, went back to his garage and got out Scientific American or some such journal and decided to connect a metronome up to a power source and an electrical and a battery and deliver sequential pulses that could pace the heart. And he brought his metronome and transistor device into the University of Minnesota, and they walked directly into the into the surgical room, connected it up. Of course, no IRBs at that time, so they just did it, and it worked. And here is Walt Lilly High with one of the earliest commercial versions of the external pacemaker. Wires passed through the chest and connected to the epicardial surface. And this was the birth of the medical device industry. It was Medtronic, and Medtronic is the largest medical device company in the world now. With when I went back there to lecture, I think they had 43,000 employees around the country. Began out of this garage in Minnesota with a guy connecting up a metronome and a battery. Now, Earl Bakken then retired to Hawaii and lived in Kona. I had dinner with him probably every year for 30 years or so. Every year there was a cardiology conference in Hawaii sponsored by the American College of Cardiology, and Earl would always come. Lovely guy, and loved to tell the story of the development of the pacemaker. He just passed away about a couple of months ago in his 90s. So that was a wonderful story for Earl Bakken and his life. He became a noted philanthropist. And Walt Lilly High became a Greek tragedy. His strength became his weakness. This is Walt as I knew him, head tilted over because of scarring from his surgery on his parotid lymphosarcoma. And to me, he always looked a little bit like E.T., so I always thought of him that way, but I didn't mention it to him. And he had decided not to pay any income tax. So he didn't do it for 2 years. The IRS came knocking on the door, and they notified him, and he paid. And then for the next 3 years, he didn't pay any income tax. Now, that's a good way to really irritate the IRS. And so they decided to make a showcase of his behavior. And they discovered that he had failed to declare $250,000 in income from 318 patients that he had done surgery on. And so there was a public trial, and they then went into his deductions. They found that his patient's anniversary had been, his parents' anniversary had been deducted as a business expense, and that he had a Las Vegas prostitute that had been deducted as a secretarial expense. And they brought the young lady into the trial, and she testified that secretarial services were not really her strength. He was humiliated in the trial. Then, in addition to that, forensics revealed that he had altered, or someone had altered, the data on his records because they had used different ink. So he had both tax evasion and tax fraud. And he was convicted by a jury of his peers on all 5 counts that were brought against him. He was fined, but the judge could not bring himself to jail Walt Lilly High Walt Lillehei would have probably won the Nobel Prize had he not got into this difficulty. And he went back to Minnesota. He was then chief of surgery at New York Hospital Cornell. And back at the University of Minnesota, he was completely ostracized. He'd go to a country club with his lovely wife, Kay, and people would come over and talk to Kay and completely ignore Walt as if he was not sitting there at the table. His Minnesota medical license was revoked. All the honors that he was due to receive and did receive up until that point, visiting professorships and honors, disappeared. And then perhaps the most poignant moment in American cardiology, this man, John Harkin, became a very prominent cardiac surgeon also in Minnesota, was elected president of the Cardiac Thoracic Society. And he, at his inaugural address, said this, among other things. He spotted Walt Lillehei in the audience, and he said, he was and still is a great hero of mine, one of cardiac surgery's greatest innovators. Dear colleagues, may I depart from my text to ask this pioneering surgeon to stand to your applause. Walt Lillehei, may we see you. And Walt Lillehei stood to the applause of 1,000 hands. And I like to think that in that moment, he was accepted back into the fraternity of American physicians. He went on to live to 80 and had an 80th birthday party. And who came to his 80th birthday party but young Pamela, the girl that I showed you in that first surgery, a very poignant story. So now, able to operate on arrested heart, cardiac surgeons were desperate for another technology. And that leads us into this guy, an astonishing story again. This is Verner Forsman. He was a 24-year-old German internal medicine resident who developed the idea, he's reenacting here, proposed to pass a tube into the heart because he thought maybe he could better treat heart disease if he could deliver drugs directly to the heart. And so he was in a promising position in his hospital, which is about an hour northeast of Berlin. And he romanced nurse Gerda Ditzen to participate. He was in a sea of nubile nurses at the time, and so he was very appealing. She had a particular trait that endeared her to him, and that was she had the keys to the supply cabinet. And so he took her, and she got appropriate supplies. They went to a remote area of the hospital, to a room. She lay down. He strapped her down, and then he cathed himself. And he then, with this catheter dangling from his arm, he and Gerda Ditzen walked to the basement where the fluoroscopy unit was, and got this image to prove that he had passed a catheter into the heart. And this is the tip of the catheter right here. You can see it here coming down. It's in the right atrium. So he was, for having succeeded in doing that, was considered crazy, and he was denied cardiology posts across Europe, and so he entered urology. He had actually used a urologic catheter, because there were no cardiac catheters at the time, to catheterize the heart. And so he published, however, his work in Germany's leading internal medicine journal, and 10 years later, two US doctors, Coronary and Richards, used that technology in treatment of US soldiers with hemorrhagic shock in World War II. And that technique then led to the first images of the heart because they injected contrast material. And the three of them, Coronary, Richards, and Verner Forsman, now a urologist, won the Nobel Prize in the mid-50s. People said that he was the least intelligent person ever to win a Nobel Prize, and perhaps that was true, but he certainly was a maverick, was he not? Because mavericks take risks that other people won't. So mavericks are also risk takers. And that leads to the second great paradigm shift in cardiology, the first one being Dwight Harkin with cardiac surgery. And this is, at that time, Reader's Digest was a magazine that had a feature that was called The Most Unforgettable Character That I Ever Met. And if I had been asked to write at that time, I would have written about Mason Sones. He was a kind of short, a little bit pudgy guy who probably was made fun of during his childhood. In any case, he was an extrovert who was a sartorial disaster, as you can imagine. He cursed like a sailor all the time, and he drank like one too when he got outside the hospital. And he was an irrepressible character who delighted in shocking people. In the cath lab, he kept a lit cigarette with a hemostat attached to it, and he would give a puff of contrast material and then a puff on the cigarette and then a little bit more contrast and back and forth. He was a chain smoker. And one day, as he was doing an aortic angiogram, the catheter tip, as he injected it, flipped like a garden hose right into the orifice of the right coronary artery. And this is what he saw. This is that image. He had performed the first selective coronary angiogram. Conventional wisdom at that time said that that would kill a person because you'd have a column of non-oxygenated blood, the heart wouldn't have any oxygen, and it would kill the person. And that was why it wasn't done. Sohn stood stunned as the heart did stop. It was a power injection of 40 cc's of contrast material, so it was substantial. And a few seconds later, then it started up again. And instead of falling to his knees and thanking the good Lord, Sohn walked back to his office and bellowed for everybody to hear, "I just revolutionized cardiology." And his long-suffering secretary, Elaine Clayton, allegedly turned from her desk and said, "Again?" And this was Mason Sohn's. But that was the beginning of coronary angiography, a stunning moment of serendipity. But what it shows you from the standpoint of research is that chance favors the prepared mind. When the door opened, Mason Sohn was there to walk through. Now, coronary angiography revealed our mortal enemy, the atheroma, but it didn't do anything about it. And that happened when coronary angiography fathered bypass surgery. This man, Rene Favaloro, born and raised in the Pampas, the most principled man that I've ever met in cardiology. Simply kind of a, he considered himself a country doctor who would treat the wealthy and the poverty-stricken the same. He was #1 in his class, but because he opposed the Peron regime at that point, he was banned back to the Pampas, where he went into rural practice. He came to the United States to learn cardiac surgery, which is now just beginning, at the age of 39 with essentially no money. And he had a letter that introduced him at the Cleveland Clinic. He was hired because of that. He was hired as a laboratory technician in Don Effler, the cardiac surgeon's laboratory. He was so skilled that Effler, seeing him operate, then offered him over a period of time a cardiac surgery fellowship. So here was a technician going from one to the other. And in 1967, working with Mason Sohn, the two worked together at night, going over angiograms. He did the first successful coronary bypass surgery and relieved angina. And that was the beginning of bypass surgery. He did 1,000 bypass surgeries in the next 3 years. And he was actually offered $1 million to come here to Miami to set up a program, but he was very dedicated to his own country. Mauricio, I imagine you know about him, do you not? He's a great hero in Argentina. He went back to Argentina and set up the Foundation Favaloro. And he was very proud of that because they did not only surgery but also research. And during Argentina's economic collapse, when they switched over to the US dollar as a basis, this foundation fell $50 million in debt. There was a lot of corruption involved, and Rene Favaloro, the great cardiac surgeon, perhaps our greatest, on a Sunday morning in 2000, I remember this day also, he walked into his bathroom and symbolically, in protest to the corruption, shot himself in the heart. And we lost him at that time. The technology advances that occurred, the defibrillator and others by surgery, came together in a way that nobody could anticipate, and that was the creation of the coronary care unit. And at Cedars, these two men Jeremy Swan invented it, Willie Gans added thermodilution, and George Diamond and I, these two guys, the developers, the inventors of the catheter, never did clinical procedures. So my first year fellow, George Diamond, and I did all the cardiac catheterizations in the CCU at that time. And we ended up publishing in the New England Journal, measuring cardiac index on the y-axis, wedge pressure on the x-axis. That is essentially a surrogate of the Starling curve. And as you see, there was a difference in mortality in these four subsets. There's also a different therapy for each of these, since this is no pulmonary congestion and normal cardiac output. And here's pulmonary congestion, here's cardiogenic shock. So this became used internationally in CCUs and then in cardiac anesthesia and in burn units, and it was called the Forrester classification. Hospital mortality at that time, in about a decade, because of the development of coronary care units and the technology that we brought to it, fell from 30% to 15%, and it then fell again, as I'll show you in a moment, and led Gene Brownwald, who's probably the most well-known of all the cardiologists of this era, to say, when I interviewed him a couple of years ago, the CCU is the most important advance in the treatment of myocardial infarction, which I think is undoubtedly true. And that leads us to the third paradigm shift, which is this man, Andreas Gruenzig, just as handsome as he looks in this picture. His nurses called him a cross between Clark Gable and Errol Flynn, both of whom were handsome and dashing Hollywood stars. And Andreas Gruenzig had the vision that he could force open coronary stenosis with a bladder on the catheter tip. He was widely ridiculed by his bosses in Zurich. He was an East German in Zurich, Switzerland. And over 5 years in his kitchen, and here is his stuff that he worked on in his kitchen, he tried to create a catheter with a balloon on it that could force open a stenosed coronary vessel. Failure after failure after failure, but each one getting closer and closer perhaps to the goal. Andreas Gruenzig really viewed failure as fuel, and it's an important insight that you can fail and yet succeed at the same time. His animal research was ignored. He subsequently brought animal research. This is Andreas at the American Heart Association in 1976. Nobody paid much attention to it, and he showed in the dog that he could dilate a suture-constricted vessel. And so he went back home to Zurich, and in the next year did 4 patients, got the angiograms, brought them to the next American Heart Association meeting in '77. And when he presented it, one of the few times I've ever seen an abstract presentation met with a standing ovation. About 5 minutes into the presentation, as he was showing these angiograms, people started murmuring, "Do you see that? Oh my God." And at the end, he had a standing ovation for the data that he presented. Mavericks use failure as fuel. And he became then, he was recruited to Emory. I tried to recruit him to Cedars, but I couldn't do it because I couldn't offer him a professorship, and he wanted a professorship, and Emory did. Angioplasty brought wealth to Andreas because he had deals with catheter manufacturers. And he bought this mansion in Atlanta. He staged lavish parties there. He also bought his own plane here and flew to a cottage on Sea Island, which is about an hour's flight south of Atlanta. And he divorced and married this young lady, Margaret Ann Thornton. I first met Andreas before he became well-known. He was at a conference in Aspen, and he arrived, and it was a speaker's dinner. He and I both arrived late with our wives, he with his first wife. And so just the 4 of us sat and had dinner together. And Andreas was a charismatic, charming guy. And my wife was just smitten with him. And from then on, I really hated Andreas Brunswick. But in any case, Andreas bought his own plane and flew to a cottage in Sea Island, and it was during a Hurricane Juan that he decided to come back because one of his patients that he had done was having difficulty. So he tried to fly home, and he crashed into a Georgia cornfield at 300 miles an hour, completely disoriented, thought he was going north when he was actually going south, and completely lost sense of space. He had only 50-some hours of instrument flying, so he really should not have been flying at all. And that then led to the invention of primary angioplasty. This is Jeff Hartzler. We called him Cowboy Jeff because he actually came to work in cowboy boots. And he was the son of a Mennonite minister. He was a terrific guitar player. He actually had a band called Heart Rock. They made CDs and sold them on the side. And he was very aggressive. He did multiple lesions when he did angioplasty. And he had one where a patient was scheduled for stable angina to have a procedure done, and he got a call in the morning saying he's having a myocardial infarction, so we're canceling the case. And Jeff said, well, wait a second, I was just going to do the angioplasty, and now I'm not going to do it just because he's having a heart attack. And so he went in and did the angioplasty, first primary angioplasty done by Jeff Hartzler. And it turned out that, of course, he did extremely well. And mortality rate for MI was again cut in half, now down to maybe 7% or 7 or 8% by that procedure. So Jeff was witheringly criticized early on for primary angioplasty because, again, everybody thought it was a terrible procedure to do in a person having a heart attack, and turned out not to be. The breakthrough to prevention of coronary disease occurred with this man, Akiro Endo. He is still alive. He was a biochemist at Sankyo in Tokyo. He, in an amazing study that I can't imagine anybody would want to do, he screened 6,000 fungi solutions over a period of 2 years with the idea that he might find a cholesterol synthesis inhibitor among them. There was reason for him to think there might be one. And his work was considered irrelevant. He did discover 2 of them, and he was, one of them turned out to be a statin, and so he discovered statins. He was fired by Sankyo because they thought his work was so unimportant. And 18 years later, Merck bought the technology essentially for how he produced the statin. They didn't produce the drug, and they produced simvastatin, and they produced a 42% reduction in mortality in patients given simvastatin versus placebo. And that was the beginning of the randomized trial era of statins. So Mavericks, this guy, can you imagine over 2 years coming in every day and adding a solution of fungi to a liver membrane preparation, and then seeing if it broke down cholesterol synthesis? He did that every day in kind of a rabbit warren next to a subway station in Tokyo, and he succeeded. So where does all this creativity lead us today? Well, that man that I don't know if I can we, I don't know if I have go back. Can we go back? If we can't, it's okay. The image that I have on the preceding slide was Charles Beale, who was the head of patent office in 1908 or so, and he said,
what is it?
Okay, great. No, that went forward. There is no bottom left, yeah. I got it, okay. So here's Charles Duell, and he said, everything that can be invented has been invented. He's the head of the patent office. But it turns out that really isn't the case. There's still room for you. And here is Dwight Harkin's hand with the microvalve splitter. And here is what happened years of work following that. This is Alain Cribier, one of my former fellows in the early years at Cedars. This is Raj Makkar, who was taught how to do TAVR by the inventor of TAVR, Alain Cribier. Raj now has, I think, the highest volume in the United States of TAVR. Did about 600 last year. And this is the 3 generations. This is me, past, present, and future. And here is Dwight Harkin's hand. And here is a TAVR placement that you're all familiar with by now. Astonishing procedure. And here is the mitral clip. Saibal Kar does that. He had 230 procedures last year, and it is the highest volume in the United States. And here is a mitral valve being put into place. This is a tough procedure. I don't really recommend it for widespread use as yet, percutaneous placement. So here is the evolution of the valves from Dwight Harkin. Here is Mason Sohn's, Claude Beck's defibrillator, and now this is what we're using at Cedars, a pea-sized or piece of rice-sized pacemaker that can be implanted in the myocardium. Here's the balloon that I used at Cedars, the tip of the Swan-Ganz catheter. Now there is this device that can be embolized into the pulmonary artery, and in clinical trials has reduced hospitalizations in people with heart failure by about 50%. Here is Grunzig's first catheter that he developed, and now work that has not yet succeeded on a biodegradable stent. This is a biodegradable stent in an animal. So there is still lots of advances to be made. And the greatest medical achievement of our time, well, I think that the golden age of cardiology, which is still going on, deserves consideration. Perhaps the advances in genetics will ultimately succeed that in your lifetime. But what we did in my lifetime was develop cardiac surgery, cardiac transplantation, pacemakers, defibrillators, angiography and angioplasty, statins. So I am very excited about all the things that we managed to accomplish. But for the future, I am jumping up and down about what we can do now. Valve replacement and repair without surgery, wireless defibrillators, biodegradable stents, cardiac regeneration is possible, and perhaps in the future, a transplantable animal heart. All for things for you to think about as we look forward to the future. So I'm very excited because as I look around here and around the country as I travel, I see a lot of Mavericks. And for all of them and for us, the past is a prologue for what I believe will be a great future for cardiology. So thanks so much for having me here to visit you at the University of Miami.